Are you
Okay, Dr. Kim, it's all yours.
all right? Are you able to hear me?
Yes.
Yes. Okay. So there's something wrong with my camera on my laptop, so it's not showing me. But hopefully this works if I share the screen. So I'm Dr. Kim. I'm a neurointerventionist and a vascular neurologist at Virginia Hospital Center. Let me just see if I can share this. Right down below and follow. Every Wednesday, you would just say hello to some people from Prestige Rehab. Yes. Give me one moment. Are you able to see my PowerPoint?
Yes.
Okay. So I'm a vascular neurologist and a neurointerventionist at Virginia Hospital Center, meaning that I specialize, I'm a neurologist that specializes in strokes, brain bleeds, aneurysms, any blood vessel issue of the head and neck or spine. I do endovascular procedures in the brain and spine, so which that just means that I take a small catheter and wires through the arteries and go up into the brain and do procedures. So I'm going to do a quick talk about cerebral aneurysms. So aneurysms develop when are you able to see my pointer?
You might want to switch to slideshow view.
Okay. All right. Are you able to see my pointer?
No.
No. Okay. So if you look on the upper left, aneurysms develop when you have blood flow that flows through the artery and hits the wall of the artery and flows into an outpouching that causes pressure on the blood vessel wall, leading to the growth of this small aneurysm, which will steadily grow larger over time. And as you look on the upper right, you see this really nice flow model of how blood flow goes into the aneurysm. It goes through the artery, it flows into the dome of the aneurysm in a swirling pattern, and then flows out. So there's pressure on the wall in the aneurysm, and there's this turbulent flow within the aneurysm. Worldwide, the prevalence of cerebral aneurysms is about 3.2%. In the US, there's about 6.7 million people walking around with an unruptured aneurysm that translates into about 1 in 50 people. About 30,000 people in the US suffer a brain aneurysm rupture and what we call a subarachnoid hemorrhage. That's the type of bleeding in the brain you have when you have an aneurysm rupture. It's essentially 1 every 18 minutes someone suffers an aneurysm rupture. The average age is around 50. There's a female preponderance, so the females are twice as likely than males after the age of 50 to have a brain aneurysm rupture. The suspicion is that the theory is that there might be something related to decreased circulation of estrogen and collagen content of the blood vessels. And about worldwide, there's about 500,000 deaths from brain aneurysms a year, and half of those deaths are younger than the age of 50. The risk factors for aneurysm growth and development are smoking is one of the main risk factors, preventable risk factors. The other risk factors include hypertension, advanced age, alcohol use, atherosclerosis or plaque buildup in the blood vessels. Some people have a genetic condition that predisposes them to aneurysms. So polycystic kidney disease or FMD is fibromuscular dysplasia. Some people have Ehlers-Danlos syndrome, Marfan's disease, if you have AVMs. Marfan's disease are those people who are really tall and skinny and have hyperflexible joints, those patients actually have a genetic condition called Marfan's. Aneurysms run in the families about 20-25% of the time. So if you have a first-degree relative who has an aneurysm or subarachnoid hemorrhage, you have a 2 to 5 time increased risk of having a brain bleed yourself. So just interesting fact, if you look on the bottom right, the first Marlboro man, who is, the icon of the smoking advertising industry, he actually never smoked a cigarette in his life, and he died at the age of 90.
Dr. Kim, do you need to advance your slides?
I am advancing. Are you able to see it?
I'm still only seeing the second slide.
Are you seeing the third slide now?
No.
Okay. Give me one sec.
There we go.
All right, let's do this. Are you able to see this?
Yes.
The third slide? Yes. Okay. Can you see my mouse?
Yes.
Okay. So clinical presentation of subarachnoid hemorrhage. The classic sign is the sudden onset worst headache of the life, or a thunderclap headache. That is a major clue that someone is having a brain aneurysm rupture. Other signs, the patient may lose consciousness, be drowsy, vomit, have severe headache or neck pain. The signs that we see in the hospital, people have meningismus signs. That just means you have headache, neck stiffness, nausea, vomiting. Photophobia just means bright lights bother you. There's also something called a Kernig sign or Brzezinski sign. So if you look on the bottom right, a Kernig sign, if you lift the patient's leg up, it causes pain and the patient will have flexed their neck due to the pain. That's just related to meningeal irritation due to the blood. Sometimes patients will present also with seizures. Okay. Are you able to see this slide?
Yes.
Yes. So the diagnosis of subarachnoid hemorrhage, whenever someone comes in with the worst headache of their life, they immediately need to get a CAT scan of the head. And that CAT scan is very sensitive for showing acute blood. So it's like 92% sensitive for showing blood within the first 24 hours. And as you can see, this CAT scan, you see these brighter areas right here in the subarachnoid space. So this is blood. This is diffuse subarachnoid hemorrhage. So all the bright spots you see right here, that's a ruptured aneurysm and subarachnoid bleeding. You can see here too, there's areas of the bright spots here, that's bleeding. So you need to get an initial CAT scan, then you need a CTA of the head and neck that is just looking at the blood vessels. The CTA will demonstrate the aneurysms that you have. So this patient had a very, very giant aneurysm of the left carotid artery right here. Here's a carotid artery, and here's this giant aneurysm outpouching here. Or it can show, an abnormally shaped aneurysm here. Sometimes, if the patient looks like they are having a subarachnoid hemorrhage and maybe the amount of bleeding is so minimal, you don't really see it that well on a CAT scan, the patient may need a spinal tap to see if there's any blood in the cerebral spinal fluid. That helps to determine if they have an aneurysm. And then they will also need a diagnostic cerebral angiogram. That's a procedure I do. It's minimally invasive. We go through the arteries with the catheters and wires and inject dye. And you can see here at the bottom left, there's a patient with a very large, I would say, giant aneurysm in the carotid artery. And you can see these 3D images. Also, the patient has a very large aneurysm here. When we do a spinal tap, we're looking for blood products in their cerebral spinal fluid. So CSF is just an ultrafiltrate of plasma. It's in the ventricles in the brain and spine. So just the CSF circulates throughout your brain and spine. It's constantly being produced by your body and constantly being reabsorbed. So when we do a spinal tap, we just have the patient lay down or bend over, and we put a needle in. This is the level of the spine. So the needle is always placed below the level of spine. So contrary to, I don't know, popular belief, you cannot be paralyzed from a spinal tap because the needle goes well below where the spinal cord ends. And we pull out some spinal fluid, which should look classically, it should have this very clear gin-like appearance. That's the way you're taught in med school. It looks like gin, right? So I always tell med students, don't taste it, even though it looks like gin. And so what we do is we spin it down. If there are any blood products there, it'll show what we call xanthochromia. So if the patient does have subarachnoid hemorrhage, we get a spinal tap and we spin it down, you will see this yellowish tint to it. So this suggests that the patient did have bleeding in the brain. And it's when we do the spinal tap, it's 100% sensitive for detecting if someone had a ruptured aneurysm. So the natural history of subarachnoid hemorrhage, usually these hemorrhages occur during non-stress strenuous activity, rest, or sleep. So when I asked patients what they were doing when they had their worst headache of their life, their thunderclap headache, they were shopping for groceries, they were watching TV, they were cooking, they were outside smoking a cigarette. It's always something not strenuous. It's really not related to exercise or anything like that. I've only had one patient have a ruptured aneurysm while arguing with her husband, but 99% of the time, it's just a completely random event, not related to activity. So the approximate outcomes when someone does have a brain aneurysm that ruptures is still very devastating to the patient. 25% of patients die essentially immediately before EMS even arrives to them. They've already passed away. And so there's 25% of patients die within the first day. 25% of patients die within 30 days due to complications of the subarachnoid hemorrhage. And about 25% of patients are permanently disabled. Those that survive are permanently disabled. So when the patient, if there is a suspicion that the patient is having a subarachnoid hemorrhage, they need to go to the ED immediately and get a CAT scan because aneurysms, when they rupture, they clot off quickly, but then they can re-rupture again. So about a quarter of the patients can re-bleed within the first day, and that leads to a 70% mortality. So if you have an aneurysm that ruptures and somehow you survive, if it rebleeds again, there's a 70% chance of death. Okay. So interesting picture here. You can see this patient came in initially with the subarachnoid hemorrhage. You can see the subarachnoid blood bright spots here, right, in the sylvian fissure in the subarachnoid space. They got a CTA, which showed a little aneurysm, not little, but a decent-sized aneurysm here in the anterior communicating artery. They repeated the CTA, and you can see from here to here, there's definitely more blood in the area. So what happened was the aneurysm re-ruptured acutely, and on these 3D reconstructions, you can see this is the actual aneurysm here, and this is contrast flowing out of the aneurysm, meaning that the aneurysm is actively bleeding. There's a hole in here, and it's actively bleeding and leaking contrast. So what we're seeing here is contrast, which is very interesting.
Dr. Kim, we've got a couple of questions, if you'd like to take care of them.
Yes, sure. Can you, let me see.
Yeah, I can read them to you.
Yeah. Okay, great. Yeah.
One of them is, you didn't mention it, but does having migraines or having had a bad concussion put you at a higher risk for aneurysm?
No.
Okay. Do blood thinners increase the risk of an aneurysm?
No.
Okay. In the the one picture that you showed earlier that showed aneurysms that hadn't burst, they said, is it good to get it this early? And somebody asked, can you be screened for aneurysms?
Yes. With a CTA or MRA. So if you have a concern, ask your primary care physician for MRA. You need some indication. So if you have headaches or you have a family member who had an aneurysm, just ask your primary care for MRA of the head. It's always better to deal with these things, obviously, before it comes to this, right? Nobody wants to deal with this in their life. So yeah, it's always better to screen. But I'll go back to that later. Any other questions?
No, that's it for now.
No. Okay. So when patients do come in for with a subarachnoid hemorrhage, we have different grading scales that we use. So there's a Hunt-Hess scale that just suggests the patient's 30-day survival. It's dependent on how the patient looks in the ER. So if they're asymptomatic with a mild headache or neck pain, there's a 70% chance of survival at 30 days. If the patient presents to the ED in a coma or what we call posturing, there's decerebrate or decorticate posturing, there's a 10% chance of survival within 30 days. The posturing is, you can see the depiction of what posturing looks like. And then there's another grading scale we use, which is a Fisher scale, which just looks at the amount of blood that the patient has, and it gives you the risk of the patient having vasospasm within the next 2 weeks. And I'll talk more about vasospasm later, but that's essentially just spasming of the blood vessel. The complications of a subarachnoid hemorrhage, one of the first things that people can develop is hydrocephalus, which is obstruction of the cerebrospinal fluid reabsorption. So if you look here, this is a normal CAT scan. You see this ventricles are very small here, these little slit-like spaces in the ventricles here and here. If you have blood products clogging up your ability to reabsorb your cerebrospinal fluid, these tiny ventricles here will expand greatly here to this size. And so what happens is that the hydrocephalus is because you have increased pressure, it causes increased pressure in your head, which can lead to severe neurological disability or death quickly. So the hydrocephalus can develop in about 20% of patients, and it can start within minutes to hours. Okay. You also develop hyponatremia, which is low sodium. It could be due to hypothalamic injury or different, SIDH or cerebral salt wasting. I want to go back to this hydrocephalus. The initial treatment when someone is developing hydrocephalus is to put a drain in, an external intraventricular drain. So you can see here, there's a drain going into the ventricular space, and essentially just drains out the fluid and relieves the pressure. So that's the first life-saving measure that people will have performed. Up to 26% of patients can have seizures. So here's the EEG of someone with non-convulsive status. So normal EEG, when you put electrodes on someone's head, looks like this. Continuous seizure activity will look like this. So this is someone who's having generalized seizure. Up to 18% of patients can have non-convulsive status, which essentially are silent seizures. Your brain is seizing, but your body is not shaking, like with classic seizures. So that can actually happen in an ICU setting in this, with patients with subarachnoid hemorrhage. It looks like they're laying there comfortable, they have a breathing tube, they have the drain in. Maybe they're comatose because they are sedated for the breathing tube, but about 18 to 20% can actually have continuous seizure activity in the brain, not translating to physical shaking activity. So that's an issue because that needs to be treated with seizure medications to stop that, abort that seizure activity. 23% of patients could get pulmonary edema, so essentially just fluid buildup in the lungs. 35% develop cardiac arrhythmias, and some of them can be life-threatening arrhythmias of the heart. So you can get torsades de pointes, which is just twisting of this EKG. That could lead to rapid death. About 21% can develop swelling of the heart, so something interesting called Takotsubo's cardiomyopathy. The reason why it's called that is this is like a Japanese octopus trap. If you can see here, it's an octopus trap called Takotsubo. And what happens in this condition is that your heart can change from a normal shape like this into something that looks like this. So this was described as looks like a Takotsubo trap. So that's called Takotsubo's cardiomyopathy. Up to 70% of patients can develop vasospasm, which is just constriction of the blood vessel, and sometimes 30% of the time this can be symptomatic. So if you look at this angiogram here, this is the patient's left carotid artery, middle cerebral artery, anterior cerebral artery. So the patient's eyes are here and here. His patient's nose is here. So if the patient develops vasospasm, this normal blood vessel will look like this. You see that the caliber of the blood vessel will constrict significantly, which will decrease blood flow. And if you have narrowing of the blood vessel, decreasing blood flow, you can develop strokes. So vasospasm is a risk factor for stroke. So this can turn into this, which is, you see the bright spots, these are multifocal strokes throughout the patient's hemispheres on both sides. Here, 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 everywhere. On the right side, in the front, on the top. So what we call this is delayed cerebral ischemia or strokes. This occurs about 30% of the time in the patients with between 4 to 14 days. So when someone comes in with the subarachnoid hemorrhage, they need to be closely monitored in the ICU for up to 2 weeks. So, once you come into the ED, you need initial scans. You might need a drain for hydrocephalus. You need to have your aneurysm treated, and then you're going to stay in the ICU for 2 full weeks being closely monitored, because if there's evidence of vasospasm, we need to treat that. So there's medications we can give or procedures we can do to reduce this spasming, because we don't want this to occur, right? If you survived your initial aneurysm rupture, this is a potential next bad outcome, is having multiple strokes everywhere from it. And the reason for vasospasm is the subarachnoid blood, as it goes into the subarachnoid space and gets broken down, it causes irritation of the blood vessel and leading to spasm. So treatment of aneurysms, this is going back to one of the initial questions. If you get screened and you are found to have an aneurysm, or say you have an aneurysm rupture, there's 2 main ways to treat it. There's a surgical method and an endovascular method. A surgical method is where a vascular neurosurgeon will remove a piece of the skull, go in, and place a clip like this across the neck of the aneurysm. So essentially, you put it across and you close the clip, and it squeezes the aneurysm shut, the neck of the aneurysm shut, so blood flow can't get in. An endovascular way, what I do is I do a tiny puncture at the artery in the groin. I go in with catheters and wires, and then I go in with a microcatheter into the aneurysm, and I fill up the aneurysm with platinum coils. So these are very small, very soft coils, literally made of platinum, and I fill the aneurysm up from the inside. So it's like filling the inside of a balloon up with soft metal wire, so it prevents blood flow from entering the aneurysm. If you do endovascular procedures, there's no cutting of the head or surgery of the head at all. There's just a tiny skin nick in the groin area. So if anybody's ever had like a cardiac cath procedure, it's the same thing. Instead of going to the heart, I go into the brain. So we use, I do a tiny puncture here at the right femoral artery, and I go up the aorta, and I go into the carotid artery. We first inject dye to do an angiogram to get a good picture. The procedure is done with a biplane angiogram machine, so it's a machine that looks like this. And we use a variety of catheters to navigate into the blood vessels, as you can see down here. There's different ways to coil an aneurysm. We can just enter the aneurysm with a wire and catheter and fill it up with coils. Sometimes aneurysms will require the use of a stent. So an aneurysm like this, with a wide neck, you might have to put a stent across the blood vessel, then fill the aneurysm up with coils, or you might need a balloon to help coil the aneurysm. So you can inflate a balloon across the neck of the aneurysm and then seal up the aneurysm itself. Or you can use a newer device called a flow diverter stent, which I'll get into in a moment. So here's an example. This is a patient who came in with a ruptured large ACOM aneurysm. You see this big aneurysm here. I filled it with, I think it was 24 coils. So I sealed up the aneurysm here. This is an X-ray of the patient's skull. You can see this dense coil mass here. And then this is the end of the procedure. You can see the aneurysm is completely obliterated compared to the initial. and the coil mass looks good. So this is a good outcome. The patient actually did really well afterwards.
Dr. Kim, we've got a couple more questions.
Yeah.
One of them is the term brain bleed the same as a term? Does that mean an aneurysm?
No, there's brain bleed is just a general term. There's a lot of different types of bleeding you can get in the brain, and only a subset of those are due to aneurysms. You can get bleeding in the brain from high blood pressure or trauma, traumatic bleeding, contusions. Sometimes when you get older, people have spontaneous bleeding in the brain. That's something called amyloid. So there's a lot of reasons to get bleeding in the brain.
Okay, can someone with normal blood pressure have or develop an aneurysm?
Yes. Most of the time, it develops spontaneously.
Okay. Somebody said they're a little confused. What's the difference between an aneurysm, a stroke, and TIA?
A stroke is, when people say stroke, they generally mean an ischemic stroke, which is a blood clot forms somewhere in the body, like the heart, and travels up to the brain and closes off a blood vessel, causing symptoms. That's a stroke. A TIA is a transient ischemic attack, meaning that the same thing happens. A blood clot goes into a small part of the body, a small part of the brain, causes symptoms, but it dissolves on its own, and then the blood flow is restored so the symptoms go away. So the TIA will present with stroke symptoms, but it will last less than 24 hours. An aneurysm is on the opposite side. So it has nothing to do with blood clots. It's related to bleeding. It's the opposite.
Are there ways of preventing aneurysms for older people, such as better diet or exercise? You've mentioned smoking and alcohol.
Most of the time it's spontaneous when they develop. Rarely it's genetic or related to like a genetic disease a patient has, or it's familial. And then sometimes it's related to uncontrolled high blood pressure or smoking. But there's nothing else you can do. It's just a random thing that develops.
Will going to a higher elevation, up in the mountains, have any effect on your likelihood of developing an aneurysm?
No.
Okay. And that's all the questions we have for now. Thanks.
Okay. So a newer technology is something called a flow diverter stent. So a regular stent looks like this. A flow diverter stent looks like this. There's higher metal content. The holes are much smaller, as you can see. And so what happens in an aneurysm is blood flow goes in, swirls around, and comes out. When you place a flow diverter stent across the aneurysm neck, the holes are so small that it significantly reduces the blood flow into the aneurysm. And when that happens, the aneurysm clots off and then gradually shrinks and disappears over time. So you can see this X-ray of a patient with a flow diverter stent across their aneurysm here. And this is a nice depiction. When you place, this is a model. If you have an aneurysm here, you can see the flow dynamics within the dome of the aneurysm. When you place a stent across the neck of the aneurysm, it's reduced a little bit, but there is still this flow across it. And then when you put this flow diverter stent across the aneurysm, there's significantly reduced flow. Sometimes people will place two flow diverter stents. You can see here, there's one flow diverter stent here, and then there's the second flow diverter stent here and here. These are just models. And you can see that when you place two across the neck of an aneurysm, there's significantly more metal coverage across the neck of the aneurysm. So this is a nice flow model. You can see it's large aneurysm without any treatment here. The blood flow goes in, swirls around, and comes out. If you place a single flow diverter stent across it, there's reduced blood flow, but it's still significant. And then when you put two flow diverter stents, there's significantly reduced blood flow. Here's some examples. So there's a giant aneurysm off the patient's carotid artery here on the right. And here's a 3D model of it. A flow diverter stent was placed across the aneurysm neck, and you can see immediately after it was placed, there's significant reduction of filling of the aneurysm compared to here. And then this is a long-term follow-up. The aneurysm is completely obliterated. This is the normal carotid artery. There's no aneurysm here anymore. It's completely dissolved and obliterated. So compare this to this. This is what the patient started off with. And now this is after a flow diverter stent. Here's another example. One of my cases is a patient with a giant aneurysm here off the carotid artery. Here's a 3D model. I placed a flow diverter stent here. If you can see this stent across from here to here. And then this is the immediate follow-up after I place the stent. You can see a significant reduction in the blood flow into the aneurysm compared to before. So this is an immediate effect after placing the aneurysm. So this patient needs a one-year follow-up study to see if the aneurysm is completely obliterated or not. And then here's another example of a flow diverter stent. So this is a patient with the aneurysm off the ophthalmic artery or near the ophthalmic artery and the carotid artery here. So you can see this aneurysm here. I placed the flow diverter stent across from here to here. Okay. And then here's the follow-up, one-year follow-up. The aneurysm is completely vanished. It's obliterated, and all the blood vessels look great. The ophthalmic artery is still here. Okay. So I think that was the end of my slide. Hold on, give me a sec. Okay. That was it. Any questions?
Yeah, somebody wanted to know, when you're doing these procedures, how do you know where you are inside somebody's brain? Do you have a camera or some kind of x-rays going on? How do you know?
Yeah. The x-rays are going on outside of the patient's head. And the way I know where I'm at is that I'm injecting dye through the catheter. So that fills up the blood vessels and tells me exactly where I am.
Okay.
I'm too lazy to type. Once you have an aneurysm, are you at increased risk for having another one?
Yes, there are 25% of people with one aneurysm harbor a second aneurysm somewhere else.
But not necessarily in
the... Oh, I'm sorry, in the brain itself. Yes.
Oh, either
in the
place.
brain.
I didn't know.
So... Yeah. There is also a relationship between aortic aneurysms in the stomach and chest and brain aneurysms.
Oh.
Yeah, there is a relationship between the two.
So if you have an aneurysm in your stomach or chest, you're likely to have one in your brain?
Not likely, but there is an increased risk of having one. But right now, I think that they have not changed the indication for screening the brain if you have like an aortic aneurysm and vice versa.
Another question is, when having the symptoms that you mentioned earlier, why is it important to call 911 rather than drive yourself to the hospital?
You do not want to be driving yourself to the hospital when you are having a brain aneurysm rupture or stroke, because you're probably not thinking clearly, even though you feel like you are, and you can pass out and die in the middle of the road.
Are the stents that you're putting in permanent? Do they get replaced?
They're permanent.
Okay. Does having an aneurysm in different parts of the brain have different outcomes for the patient?
No, it should be the same outcome.
Okay.
So this is Wendy. Dr. Kim, after having seen all the slides and having a better sense of mechanically what's going on and the tools that you use to treat it, can we go back to the beginning in terms of how do you know if you're having one, or what are the diagnostic tools you can use to anticipate? It sounded like one was the worst headache of your life. So if that happens, call EMS or have somebody else drive you to the hospital. Can you go back over what the other uh, tools are that would give you a warning of an aneurysm, if any?
Clinical tools? I mean, clinical signs?
Yes, any?
You mean
The
symptoms,
clinical sign
Wendy?
Yes, symptoms. Thank you.
Yeah. The symptoms, sometimes chronic headaches can be related to an aneurysm. That's why if you go to your primary care and, they may get an MRI and an MRA if you have chronic headaches. So, the problem is that aneurysms present two ways. Either someone has migraines for a long time and then they go get an MRI and they are incidentally found to have an aneurysm, or it ruptures and, there's a 50% chance of death. So, there's no guideline right now for screening everybody unless they have some existing issue with headaches or, family history of aneurysms. So it's mainly just one of those two things. Either you have the worst headache of your life and you have a brain aneurysm that ruptured, or you go to your primary care and you have migraines for years and then they get an MRI and they find the aneurysm on the workup.
Somebody wanted to ask, where did you get your degrees and how long have you been at VHC?
I've been here for 5 years. I got my degree at St. George's Medical School, and then I did my training in residency in internship in New York at Elmhurst, and then residency at Stony Brook, New York. And then I did my first fellowship in Case Western in Cleveland, and then the second fellowship at Leahy Clinic in Massachusetts. All over the place.
Okay. Somebody mentioned face drooping, trouble on one side of the body, like walking, lifting arms, etc. Is that more symptoms of a stroke rather than an aneurysm?
Yes.
Okay. If someone has an aneurysm at home, other than calling 911, what else should they do?
Nothing. Just call 911. Don't get in your car. Don't have your friend take you or spouse. Just call 911.
Should they lie down?
They'll get you there quicker.
Right.
Yeah, lie down because you might pass out and hit your head.
Okay.
No need to take aspirin either. Just call 911. We'll figure it out in the ED.
You mentioned that women are more likely to have aneurysms. Are there other factors like do different races have a higher propensity?
I would have to look into that if there's a difference in I would have to look into that. For other neurological conditions, there's a definite difference. Like Caucasians have more atherosclerosis in their neck, in their carotid arteries in their neck, and I think Asians have more atherosclerosis in the blood vessels in their brain. It's like reversed. So, but for aneurysms, I would have to look into that.
Does it take a long time for an aneurysm to develop?
Yes, it takes years.
Okay. And somebody's asking, what about taking an aspirin?
No aspirin needed. Just get to the ED.
Okay. And you said lie down. I assume that's lie down on your back?
Yes.
Okay.
Yeah. So, I'm sorry, but I have another procedure I have to get to. I apologize for not being able to take everyone's questions, but I have another procedure I have to run to.
Well, we don't have any more questions, so you've handled everything.
All right. yeah, I hope my talk was helpful and interesting. And if anyone has concerns, just ask your primary care for an MRA. Just look at your blood vessels. Okay.
Thank you.
Thank you very much.
All
This
right.
was
Thank you.
very
Thank
informative.
you. All right.
Thank you,
Thank you.
Dr.
Bye.
Kim.
Bye.
Bye-bye. Well, anybody got anything else they want to add?
No, Gary, you saw Mike Joe. Getting Zoom
Yes.
to work is harder than brain surgery.
Yeah.
I had also just added on the there that in addition to, I put the link for when I had Dr. Kim on the Aging Matters radio, but I would also suggest, I noticed that someone in the chat had indicated the various symptoms that people can have. And there's actually, I was going back to an Aging Matters TV show that I did, episode 7, and I put that link in. It is a TV show in which there is an acronym of the different kinds of symptoms that people can have, and they can kind of remember it. But so if you have a chance, just go to the website and look up episode 7 of on the TV show page. It really shows what you need to think about in terms of I think it's face. I can go back and look, but each one stands for the facial, arms, and some other symptoms as well. But it's really important to know that if you seem like you're having some of those symptoms, to be sure and check that out. So
It looks like Melissa's trying to jump in.
Yeah,
Okay.
Cheryl, I didn't want to interrupt you. Hi, for those that didn't know, my name is Melissa Gray. I'm the stroke coordinator at Virginia Hospital Center, or VHC Health. And what you're referring to is an acronym called FAST,
yes,
FAST, which stands for facial droop, aphasia, arm weakness, speech, and T is for time. There's also another acronym out in the community called BFAST, and that adds a couple other components of patients that might be experiencing a different type of stroke, or a stroke in a different area of the brain, because obviously symptoms are related to where you're having your stroke. And that acronym is BFAST, standing for balance and coordination. You're feeling dizzy. It stands for eyes for vision. You're having some vision issues, either double vision or can't see clearly out of one eye, or things are just blurry. And then the continued acronym of the facial droop, arm weakness, speech difficulties. That could mean either not being able to speak, or not being able to say what you want to say. Like you want to say the word dog, but you can't get it out. And you're saying something different, and you're maybe not always making sense. And then the final thing again is time, and that's getting to the emergency room. Not having somebody not driving yourself, taking the time calling EMS, let EMS get you there. In Arlington, they can get you to an area hospital in under 5 minutes. With the way that things are set up and stuff. So it's very important to definitely not drive yourself, and obviously get to a place that's safe. So when Dr. Kim was referring to, if you feel like you're having the worst headache of your life and you're concerned, or you're having any other symptoms, the best thing you can do is to get in a safe position, which might be sitting on a chair or lying on your couch, or if the floor is the closest thing. So that's the other important thing, is just to get into a safe place in a position.
And if you're by yourself, unlock the door.
If you can,
Yeah.
for sure. If you can, for sure. So, but if there's more questions related to stroke prevention and warning signs of stroke, we're happy to come back at another time if you would like us to, and we can provide some of that additional information.
and Melissa, maybe you could talk a little bit more in terms of the golden hour. Isn't there something that people should know in terms of why it's so important to get, to call 911 and get an ambulance to take you to the hospital, in terms of getting that medication in a timely fashion?
So the golden hour is kind of related to a lot of different things in healthcare, just trying to get people time. But there is a time window for someone that's having a stroke. There are certain strokes that you are able to receive a clot busting medication, and there is a time sensitive window from when your symptoms started to when you can receive that medication. There are also some strokes that occur in a very large vessel, and those can actually be treated endovascularly. And that's a procedure that Dr. Kim also does. And that's a procedure that they do that they can remove a clot from a very large vessel. So there are things that can happen if you come in time. And we have patients every day that come through the facility that think they potentially are having signs of a stroke or and we get worked up and they don't have a stroke, but we're much happier having them arrive early and get worked up than wait.
Good,
When in
thank you.
doubt, call 911. Any other quick questions? I obviously wasn't really prepared for a talk, but we certainly can, because stroke prevention is definitely very important, and knowing your risk factors, because as Dr. Kim referred to, specifically aneurysms, there's not a lot of screening tools that are done to look to see if you have a risk for an aneurysm. We often find patients have had a ruptured aneurysm in the facility, and they just didn't know, or it's as he mentioned, it's just a spontaneous event that it can occur. But there's a lot of things that people can do to prevent their risk for stroke. And as he mentioned, there are two types of stroke: an ischemic stroke, which is a clot that forms in a vessel in a brain, and a hemorrhagic stroke where there's a bleed in a vessel in the brain, which is different than the aneurysm bleed per se. But they're similar in some regards.
Melissa, maybe what you could also talk about is that I think it was Carolyn who brought it up a little bit earlier about TIAs. And sometimes people don't exactly know, am I having a TIA or am I having a full-blown stroke? Can you talk about the difference?
Yeah, and as Dr. Kim mentioned, and I will have it, and we could definitely do this more offline, and I could have one of our NPs come on as well. Is TIA is that you had a blockage that resolved quickly on its own, and you started to have symptoms. You might have had the facial droop, you might have had a little speech difficulty, your arm might have felt funny, but it resolves on its own. And it resolves quickly without causing any area of injury in the brain. And those are really a big warning sign that you could have a stroke. And that is something that needs to be evaluated. People can still come to the emergency room if that happens. Like all of a sudden you're out, you wake up in the morning, you're perfectly fine, then you have your breakfast and you're going about your day, and then all of a sudden something happens and it resolves within 30 to 45 minutes. We still see patients in the emergency room with that, when we evaluate them and work them up for stroke prevention. And oftentimes it was called a TIA. It used to be called a mini stroke at some point in the literature, but now we call it a TIA, a transient ischemic attack, meaning that it did not last. But again, as I mentioned, it can lead to a ischemic stroke that does cause damage. And can be treated if we get within the appropriate time window. And there's a lot of other medications and stuff that can help with symptom management. And I don't want to, there are some obviously deficits that folks have, but rehab is huge in a patient's recovery.
Right. And is it more likely that women rather than men get the strokes, or is there certain races that are more likely?
I don't have those statistics offhand, so I don't want to speak to that, but
okay.
I'm happy to come back at another time.
Okay.
But just kind of offhand.
Okay. Well, any other questions that you are seeing, Gary?
Nope.
Okay, well, we're just about out of time. It's 10:56. Thank you, Melissa.
You're welcome. I'm sorry, I wasn't
that.
prepared for a bunch, but I'm just happy to kind of make sure.
No, that's very
to look
helpful,
out for.
especially those symptoms and remembering that be fast.
Be fast. Yeah.
That's really important. I knew I had it, but I didn't have it correctly. So I'm glad you added it. So be sure and tune in next week. The topic will be History of St. Andrew's Episcopal Church, and Lloyd Starnes and Jane Massant, I think her name is pronounced, They are longtime members of St. Andrews, and they will be giving a lot of information about the church's 73-year history. So be sure and tune in next week, same